Health insurance is the next housing bubble, and it will bankrupt you. The bill said covered. The balance said $15,000. Their insurer called it not medically necessary. The ambulance ride alone triggered collections. They had paid premiums for years. It didn't matter in the moment that counted. Here's the punchline. The 2008 mortgage playbook is running inside your insurance card. Premiums are climbing faster than wages. Denials are rising. One ER visit can crack a household's credit. Consolidation and financial engineering are accelerating this year, not slowing. Stay with me. I'll show you the mechanism that turns your health into a yield, how to spot the traps, and the moves that keep care accessible. The mechanism, how insurance became a yield product. To understand why that bill looked like a foreclosure notice, we need to go back to how health insurance used to work and how it got rewired. The original idea was simple: pooled risk. Lots of people pay in, a few need costly care, the pool covers it. Mutual insurers and nonprofits dominated, and any surplus generally cycled back as lower premiums or broader benefits. Then the incentives flipped. Shareholder-first insurers entered and scaled. The mission quietly shifted from smoothing risk to optimizing margin. What nobody knew at the time was how easily health insurance could be reshaped into a predictable yield if you controlled the definitions of care, necessary, and network. Here's where the medical loss ratio comes in. The ACA set floors. Spend 80% or 85% of premiums on medical claims and quality improvement, or rebate the difference. Sounds consumer-friendly, but the ratio isn't a break, it's a formula. If you can relabel spending as quality, if you can buy the providers who bill you, if you can mark up internal transfers, you can meet the ratio and still extract profit. Vertical integration. Insurer owns the physician group, the pharmacy benefit manager, even the specialty pharmacy, creates rooms within rooms. Dollars leave one pocket, enter another, and the MLR still looks compliant. Meanwhile, the operational levers tighten. Narrow networks steer patients to owned or preferred providers. Prior authorization turns time into a cost control tool. Delays make people give up. Denials, especially initial denials, become a sorting mechanism. Many get reversed on appeal, but a significant share never gets appealed at all. That's yield. It's not about one giant no. It's 1,000 small frictions that turn a yes into later and later into never. While that was happening with care access, drug spending became its own revenue center. Pharmacy benefit managers, now sitting inside the same corporate families as major insurers, control formularies, negotiate rebates, and decide what's preferred. The list price, the net price, and the patient price diverge. Rebates paid by manufacturers balloon, but they don't necessarily reduce what you pay at the counter. Spread pricing, the difference between what the PBM bills the plan and what it reimburses the pharmacy, creates quiet margin. Vertical integration lets that spread accrue inside the house. The result is a machine. Premiums flow predictably. Claims go out more slowly with hurdles. Pharmacy dollars circulate through a middleman you don't see. And the accounting meets the letter of the MLR while missing the spirit of it. The more complex the structure, the harder it is for employers, regulators, or you to see where value ends and markup begins. Now add consolidation. Large payers by physician groups, home health agencies, behavioral health networks, and urgent cares. Hospitals acquire outpatient clinics and attach facility fees to what used to be office visits. Site-of-service rules allow higher charges for the same service, but only if it's rendered in a hospital-affiliated setting. Shifting care locations becomes a pricing strategy. Here's the kicker. Administrative categories can be gamed without a single code word. A utilization management team logged as quality improvement. A data platform for risk scoring booked as care enhancement. It's not always illegal, it's engineered. Meet the ratio, grow the total premium base, and take your margin on a larger pie. If premiums rise 6 to 9% annually, while the MLR holds at 80 to 85%, dollar profits rise too. That's yield math. Meanwhile, the human side absorbs the volatility. High deductibles put families on the hook for the first several $1,000s before insurance really kicks in. Co-insurance ties your bill to inflated chargemaster rates, not the cash price you could have negotiated in another lane. Out-of-network surprises remain possible when a facility is in-network, but a specialist isn't. Even when laws limit surprise billing, loopholes and arbitration games keep friction alive. 3 days earlier, something else happened that explains the pressure you feel at the pharmacy counter. Formularies are built on deals. A brand drug can be favored over a cheaper alternative because the rebate structure makes the plan, or its PBM, whole. Patients pay cost sharing on the list price, not the net. The savings don't reliably reach the checkout. Independent pharmacies get hit with retroactive fees months later, pushing them toward closure. When independent options vanish, affiliated specialty pharmacies inside insurer PBM giants gain share, and markup opportunities expand. This was the moment everything changed. Insurance became less about smoothing unpredictable risk and more about predictably extracting margin across the care continuum. The goal stopped at meeting a ratio. The strategy moved to owning the pipes, setting the tolls, and controlling the traffic. Get this, none of these moves require a villain speech. They're calibrated, spreadsheet-tested tweaks. Tighten networks a bit, deny initially a bit more, reclassify expenses, nudge care to own sites, steer drugs through affiliated channels, and let complexity do the rest. Each step looks modest. Together, they reroute the cash flows. In the aftermath, households face a paradox. They're covered, yet exposed. One acute episode can wipe out a savings cushion. A chronic condition becomes a billing marathon. Employers think they're buying discounts, but the benchmark prices are inflated before the savings apply. Regulators chase disclosures while the structure shifts. To see how we got here, we have to watch the trap being built in real time. Now add private equity, whose clock runs on debt and exits. Private equity's playbook in healthcare. Private equity arrives with a timer. The model is simple. By using debt, boost earnings quickly, then sell. In healthcare, that timer meets patients' bodies. To make the math work, they don't invent revenue, they concentrate it. They roll up fragmented practices, standardize billing, and use market power to set prices. The yield comes from compression. Fewer competitors, tighter staffing, faster throughput, higher codes, quicker collections. Start with the buy. A PE firm identifies a specialty with steady demand and messy ownership. Emergency medicine, anesthesia, dermatology, gastroenterology, radiology, hospice, dental. They acquire a platform practice, load it with debt, and add dozens of smaller groups. Every acquisition expands their negotiating leverage with hospitals and insurers. Meanwhile, debt service becomes a monthly metronome. Interest must be paid, no matter how busy the ER feels. Then comes the playbook inside the walls. Staffing ratios are recalculated. Scribes support physicians so charts justify higher evaluation and management codes. Coders get optimization software prompts. Supplies are centralized, cheaper vendors substituted. Schedules are tightened to reduce downtime. Contracts with hospitals are renegotiated with out-of-network leverage. If the group walks, the hospital loses a core service. That leverage translates into higher rates or facility subsidies. Patients never see the negotiation, they see the bill. Here's where billing power meets scale. With hundreds of providers under one umbrella, a group can credibly threaten to exit network. The threat itself extracts higher contracted prices. When they're out of network, the charges anchor to inflated fee schedules. Even after the No Surprises Act curbs certain balance bills, loopholes remain for some services and settings, and arbitration can favor the prepared. Meanwhile, collection tactics professionalize. Early pay discounts for those with cash, interest-bearing plans for those without, litigation for the rest. Yield is a funnel. Every claim, every phone call, every suit moves dollars a little faster. Parallel to the clinic, revenue cycle gets rewired. Denials are immediately appealed with templated letters. Documentation is templated to meet medical necessity bullet points. Ambiguity is an opportunity. Observation status stretched, inpatient criteria argued, bundling/unbundling calibrated. Each tiny edge isn't dramatic alone. At scale, it's a balance sheet. Add site of service arbitrage. Once a roll-up reaches critical mass, a hospital or system partnership becomes attractive. Hospital-owned outpatient departments can bill facility fees for the same visit that used to be billed as a professional fee in an office. If the PE platform aligns with a hospital, services shift into hospital-affiliated settings when possible, lifting reimbursement without changing the medical act. Patients feel it as a strange extra line on the statement, a facility fee for a routine visit. Debt shapes the next decisions. Servicing interest pushes groups to maximize throughput and cash collection. Hiring leans junior. Experienced nurses and techs cost more, so you see fewer of them on the floor. Schedules squeeze lunch into notes. Burnout rises, turnover follows, and the cycle tightens again. Patients wait longer. Clinicians code higher to compensate for time. The math doesn't break. The people do. Exit is the destination. 3 routes dominate. Sell to a larger PE fund, flip to a hospital system or insurer, or go public. Each path rewards optics, EBITDA growth, market share, clean AR, over durable community capacity. If the buyer is a vertically integrated insurer, billing power meets gatekeeping. The new parent can steer patients to its owned groups, set rates internally, and manage denials externally. If the buyer is a hospital, facility fees become permanent. If the buyer is another PE fund, debt resets and the clock restarts. This distance between the bedside and the balance sheet echoes the mortgage era. In 2006, a broker didn't hold the risk, a tranche did. Here, a staffing company doesn't carry the full patient risk. The insurer, the patient, and sometimes the hospital do. Financial layers, management companies, real estate holds, debt vehicles, buffer investors from the community's pain. A closure is a write-down upstream and a 2-hour drive for dialysis downstream. Emergency medicine shows the mechanics clearly. 2 national groups rolled up coverage for a huge share of ERs. They negotiated from strength, sometimes left networks, and pursued patients for balances. After the No Surprises Act, they shifted to arbitration and adjusted coding. When rates moved against them and debt markets tightened, one group filed for bankruptcy protection. The debts were refinanced. The ER doors stayed open barely. Staffing thinned. Wait times stretched. The investor clock kept ticking. Anesthesiology and radiology follow a similar path. Hospitals need coverage to run ORs and imaging. A single large group can demand subsidies, higher rates, or preferential scheduling. Dermatology and dental add cash pay SKUs, cosmetic procedures, implants, boutique biopsies, that smooth revenue. Hospice and home health chase per diem or per visit payments, with pressure to extend lengths of stay within rules. None of this is fiction. It's contract law meeting clinical life. Meanwhile, parallel roll-ups in behavioral health, autism therapy, and addiction treatment tap public and commercial payers. When reimbursement tightens or authorizations slow, locations close quickly. Rural areas get hit first. Low-margin sites vanish. The yield target remains, but the map loses dots. This decision would haunt communities because consolidation is sticky. Once independent practices sell, recreating local competition is hard. Prices settle higher, quality varies, access narrows. Investors exit with gains or acceptable losses. Patients inherit the operating model. When billing power meets insurance gatekeeping, it's not a negotiation, it's a vice. And we haven't even opened the denial engine that turns covered into come back later. The denial engine, prior auth, surprise billing, balance bills. Start with prior authorization, the slow no that sounds like not yet. On paper, it's a check for safety and fraud. In practice, it's a filter. Your doctor sends the request. The plan asks for more notes. The clock starts. While that was happening in New York, a cancer patient in Ohio waited weeks because a reviewer labeled the therapy not medically necessary. They didn't know the reviewer might not share the specialty. They only felt time slip. Here's why the delay matters. Half of people who run into prior auth report delays or denials. Many approvals eventually arrive, but not before pain worsens or schedules break. Some give up. That's the unspoken math. Attrition saves money. Hospitals see a different angle. Initial denials are up even as prior auth denials tick down, replaced by medical necessity or more information rejections. Staff are pulled into fax wars. Bills stack in suspense queues. Medicare Advantage adds another layer. 1 in 6 initial claims can bounce. Many get reversed on appeal, but providers still lose revenue time, and the gap hurts payroll. A Senate investigation found post-acute care, skilled nursing, long-term acute care, faces denial rates multiples higher than other services. Translation: the places that bridge a fragile recovery are the first choke point. Families feel it as a lurch. Discharge called, coverage stalled, mom stuck in the hospital another day. Then there's the trap everyone thought new laws fixed. The hospital is in network. The surgeon is too. But the anesthesiologist, the pathologist, the ER doc, they might work for a separate group that isn't contracted. The The No Surprises Act slashed much of the worst balance billing for emergency care and certain ancillary services. It didn't erase every gap. Ground ambulances are often exempt. Some facilities route services through locations or designations that fall outside protections. And when disputes go to arbitration, the party with more data and better paperwork tends to win. Out-of-network still has bite because of how prices get set. The sticker price, the charge master, anchors negotiations. If the claim falls out of network, your coinsurance might apply to that higher number instead of a negotiated rate. That's how a 20% coinsurance becomes 20% of a number nobody would pay in cash. Early pay discounts show up as a kindness. Payment plans carry interest you didn't plan for. Miss a call, and the account rolls to collections. Emergency departments show how this plays at pace. Large staffing firms rolled up coverage for many ERs. When they were out of network, surprise bills hit patients. After the law, the battleground moved to arbitration. Those firms honed documentation to justify the highest evaluation and management codes allowed. Each code is a few $100s. Across millions of visits, it's a revenue pillar. When rates compress, debt pressure rises. Bankruptcy for the company becomes longer waits and thinner coverage for you. Prior auth can turn a chronic condition into an obstacle course. One mother spends hours each month renewing approvals for her child's therapy. Miss a deadline, and sessions stop. The plan's portal times out. A fax line is busy. A specialist's note uses the wrong phrase. None of that changes the child's diagnosis. It changes access. Appeals exist, but they demand time, records, and stamina. Most people don't appeal. The system counts on that. Meanwhile, denial categories shift like a shell game. If regulators crack down on prior auth abuse, denials migrate to insufficient documentation or site of care not appropriate. Providers adjust, adding boilerplate to notes to satisfy criteria that aren't public. Insurers update rules mid-year. Patients stand in the middle, told to call back after the weekend. Ambulances deserve a pause. You don't shop when you can't breathe. Ground transport often sits outside surprise billing protections. A ride across town can cost thousands. If the ambulance company isn't in-network, many aren't, the balance lands at your door. City contracts, private operators, and insurer networks don't align on purpose. They just don't align. Families discover the exception after the siren. Collections bring a final twist. Some nonprofit hospitals promise charity care, yet send accounts to aggressive collectors while paperwork sits. Medical debt has been scrubbed from many credit reports, but not all. Court judgments still follow. Wage garnishment still happens. And while regulators emphasize leniency, revenue cycle firms are measured on recovery, not relief. Here's the part nobody explains. Denials don't need to be absolute to work. A 5-day delay can cancel a surgery window. A missing code can punt a claim into a new deductible year. A partial approval can shave sessions from 14 to 10. Each friction point moves money back toward the payer and its subsidiaries quietly. What it meant for the family at the top is simple. Their insurance card opened the door, but didn't keep it open. The ambulance bill slipped past protections. The initial denial hit on necessity. A specialist's out-of-network status hid in plain sight. By the time appeals succeeded, the balances had aged. Interest started. Savings ended. The bill you get is the output.